welcome again. Well, we have some people still in the room. I know we have some people online as well. With me is Jose, and he's going to talk about WHO Smart Guidelines approach. So welcome, Jose.
Thank you.
Go ahead.
Yeah. Hi, this is a presentation about the WHO, World Health Organization Smart Guidelines approach, what they are doing and how this impacts our work with FHIR and how our work with FHIR is helping build something better. Share. Yeah. I'm Jose. I'm a standards advisor at Digital Square and Path. We are basically putting people together to make better healthcare and provide equity for healthcare. I'm also chairing HL7 Belgium, which is kind of relevant because lots of the things that we are talking here, they start in this country and that country, and everything comes together beautifully. And my job is actually to set things on fire. So the idea for the WHO guidelines. What WHO is now doing and has been doing is to provide guidance for countries to adopt specific aspects of care. So they have to get clinical consensus on guidelines based on evidence, for example, for vaccination. What are the vaccination recommendations? Or what are the antenatal care? So pregnant women should take folic acid and vitamin D in some conditions, more or less. So they provide this guidance evidence-based. The intent is that locally, countries like ministries of health, they will adopt such guidance. And then when this happens, the technology partners will adopt this and implement systems that support those guidance, like vaccination records, vaccination schedules. And then it gets to the health workers, who will then, looking at this, they will start implementing the actual care for the patients. They will start vaccinating people. They'll start prescribing folic acid and vitamin D. So this is actually happening today. And with this, we want to provide, or we as the global community wants to see that more people have better care. This is extremely difficult to operationalize because there's lots of consensus building. There's a big chain of sharing information and adopting this. And this has been manual, consensus-based policy work that takes its time. But we are now in 2023, so we should make this better. So enter smart guidelines. Smart guidelines are not related to the Smart on FHIR platform, just for the acronym, but I think tomorrow we'll still have another three more things that are smart, that have the smart acronym. But this means standard-based, machine-readable, adaptive, requirements-based and testable specifications. So those keywords are really important. I'll get to some of them to emphasize their importance. This picture you'll see in the WHO website. It kind of synthesizes what the initiative is. And this is a set of reusable components. So things that people can take off the shelf and implement their guidelines better with less resources or more in a more speedy manner, that they can implement the same guidelines that have been published. It's a stepwise process. The concept is still the same. You provide the clinical guidance with the existing information that you have. You then prepare things, you do analysis, business analysis, process analysis, and functional analysis. You take this to the level that it's now operational. Just a side comment. The WHO guidelines is like those PDFs, those posters that you see on the doctor's office. Like, if you have this, call your doctor. Or if notice that you have to do these things. It's really abstract, high-level guidance. No, what we need to do is to transform this into concrete. So we as software developers, concrete implementable things. So the path is, you start with the existing guidance. You do some preparation, like the analysis, and then you have the actual exchangeable, computer readable specifications, and then you implement software. This has been the approach that has been taken, and we are now introducing things like level 1, level 2, level 3, and level 4. Those are keywords that are being more and more used. It just means level 1 is narrative, it's at high level, that's what we had before. Level 2 is operational, like functional things that mean something to people but are not computer readable yet. Level 3 is machine readable, that's what computers can read, enter FHIR, and level 4 is software. And this is the path that we want to take forward. Level 1, as I said, these are collected, so these are curated information, guidance, orientations, clinical, I would say the word prescription, but clinical orientations that clinicians, nurses, what they should do. it has to be, it is a consistent approach throughout the globe. The WHO wants this to be very much consensus-based, and there's a lot of people working on this to build that consensus. The level 2, so how do we make this now operational? We take that and we get not the people that are building consensus, because the consensus is being built, but now we create what they call the digital adaptation kit. We create more detailed specifications. For example, if the guidance is pregnant women should take folic acid and vitamin D, this means that as of week X, I do not know by heart, the woman should have the supplement. If there is a vitamin deficiency, then the supplement should be reinforced. Those more objective, more still human relatable, but more objective guidelines. That's what people do the analysis for. And this is the first step to then enter the level 3. Sorry, the level 2. Basically, it contains the these kind of components. So user scenarios, personas. This is pretty much for all of us. It's functional analysis. That's what we do in that sense. We create digital adaptation kit to say this is the formal objective description of the guidelines. And I wanted to get here. Level 3 is what we are used to do now. Thanks to the initiative of the WHO, this is being pushed throughout FHIR. So FHIR is the standard of choice, not only for the actual content, but for the approach to publishing this. So WHO is publishing implementation guides for those smart guidelines, and the different components, the level 2 and the level 3, are in FHIR implementation guides, which makes it much easier for a broad community to adopt it, to implement, to reuse the existing tools, and to have this implemented in the countries, thus closing the loop that I mentioned before. This consists of standard artifacts and also clinical query language for indicators and for decision support. So decision is really, if this happens, then give this vitamin D. Those are computable expressions also in the implementation guides. In fact, or in practice, what is in an implementation guide? If you look at an implementation guide from the WHO, you will see the narrative part as an introduction. You will see those artifacts, the personas, the use cases, the business process. You'll see those and requirements in the level 2. And then in the level 3, you see the machine readable stuff. Those are artifacts that we as FHIR developers are more used to see. So we have code systems, value sets, and concept maps, if it's about terminology, and there's lots of terminology there. If you are talking about data structure, you talk about profiles and questionnaires. If you're talking about workflows, you talk about plan definitions and activity definitions. If it's about the logic, you have the measures and the libraries. But also, and remember, SMART is requirements-based and testable. That has been a very important part of all of this ecosystem, that things have to be requirements-based and testable. So in the implementation guide, the expectation is that we will also add test plans, test scripts, actor definition requirements to consolidate and to make reusable, computable, machine-readable testing and testable specifications. So those are additions, not only to say how it works, but also to say how it's tested and how can it be adopted. The level 4 is the executable software. So if we give the level 3 of information for the FHIR artifacts, we will then have companies, organizations that will implement this in software. I just mentioned this here. So there's a lot happening there. Several organizations are pushing out level 4 components. Google is doing an Android SDK for this. Orna has built some applications on this. So there's lots of community interest in building up, because the platform is the same. So we just build up the systems on common specifications, which means that if the specifications change tomorrow, it's okay. We just adapt the system to the specifications. And now we are entering the fun part. The WHO guidelines, they started with antenatal care and family planning. Now we are into HIV care, so HIV monitoring, immunizations, TB, tuberculosis, surveillance, nutrition, supply chain. There's lots of things coming. Lots of things are coming our way to the community. I mean, lots of smart guidelines are being planned. They are being developed. They are being pushed out. Some of them are being worked on right now. They will be published soon. Some of them are still in the process of getting the right people on the table to see what can be done. But doing this amount of implementation guides, of specifications for global impact, this will take lots of effort, lots of resources. And those resources might not be there always available. So this needs processes, tools, and reusable stuff, reusable components. So what we have observed, so from my perspective, I've observed that WHO is pushing for increasingly for standard processes, standard tools, so that if I make an implementation guide for HIV, I will do implementation guide for immunizations in a not very different way. So trying to have that framework set in place so that more and more quantities can be made. So it's basically the industrialization of this. And the interesting part of this is that, okay, WHO makes their part, but remember the first cycle that countries will have to implement. What happens if a country has to implement something and they have to diverge a bit? So for example, in this small diagram, we have one country that this blue one would, so the first one would say, I will implement the WHO as I want. The second country will say, I just need to change something on the profile because my technical systems are slightly different. What about a country that says, and this is actually a real situation, for counting HIV cases, we need to split this into groups. And the groups might have something to do with sexual orientation. What if a country for political reasons says, we don't want that to be visible in our indicators, we want to change that. So we actually want to change the value sets that we split our population groups in. So what happens then? We know kind of what happens technically, but the problem is one of maintenance and management. So how do you make sure that if someone at the ministry says, we have to change this value set, that the whole change and the whole tools propagate that change? Because if you do that, then most likely your level 3 artifacts are no longer directly applicable to your country, because the level 3 artifacts contain code systems and value sets that were designed for the other purpose or for the other context. How do you ensure this downstream impact of changes? So this is one of the big problem areas now, or it's IT, so we are used to see this kind of impact, but it has to be at the global scale. So it has to be well managed, hence the impact. And additional things that we'll see is that, how do we test this? How do we test the effectiveness of this? So the WHO has started, as a quick reference, the clearinghouse, so a center for, or a system for checking if digital interventions are following the right criteria. There's a trust network for everything that's authentication. There's a product catalog. If you talk about vaccines, you talk about supply of vaccines, and of course we need some product catalog infrastructure. And there's also global goods, so a lot of open source software that's out there that is intended to feed into this and support as much as possible the smart guidelines infrastructure. And to wrap up, so this is how the smart guidelines are intended to work, and where does FHIR fit in this? FHIR has been fundamental for this. The whole philosophy of FHIR, that we have reusable, machine-readable specifications, this fits perfectly into the WHO initiative of smart guidelines. There's now an ever-growing infrastructure and ecosystem to support L4. Now you can actually click on a button, have an implementation guide, and have a test server to deploy these things. These are things that FHIR community has produced, is producing, and it's really interesting for adopting this, keeping in mind that this is going to be adopted in countries with lots of resources, but also in countries that have no resources. They just have to have something out there. So this is extremely important. And the FHIR community, the help that we get from the FHIR community, the methodology of pushing things out there, versioning them and going fast, this is really important for fast growth. On the other hand, the smart guidelines, by this expected volume and expected complexity of the implementations, they need more of FHIR. So a couple of things have come up from the smart guidelines and other projects, like we need standard operating procedures. My implementation guide should have a naming convention, because the next person that's going to read it is in a country that doesn't speak my language. So they should have the same kind of look and feel on how the code is written or how things are unmanaged. Authoring tools, there's lots of gaps in authoring tools. Testable specifications, it's an area that we want to put more and more emphasis. And as you'll possibly hear during this DevDays sessions, you'll have multilingual content in the implementation guides. So as a conclusion, the smart guidelines are a unique opportunity to accelerate what we really want, the provision and equity of care. That is a noble initiative from WHO. We as a community and we as providers and curators of goods, we are trying to assist this by seeing that this requires a lot of industrialization aspects, a lot of tools, procedures, things that can bring us together as a community in a consistent way of working. FHIR is an excellent enabler for this. It's fast, agile, open, and it's really community oriented. That's what we want. And the smart guidelines will indeed set some of the key tones for us, for FHIR to accelerate in terms of process, in terms of tooling, in terms of agility, in terms of how do we build these things together. Thank you. I don't know if we have questions.
Yeah, I'm coming over with the mic.
What are the expectations around SQL for the clients in these guidelines?
There are engines that are running SQL on the server, but if you mean what the client, as in the mobile application that has to run it, I think at this moment the SQL execution is considerably heavy in the sense that it might be difficult to put it there, which means that that's one of the areas we don't know yet what's the performance impact. So let's start with the server. This is what I feel from the community. We do this on the server, but maybe someone could work.
Can be smart enough to run SQL.
Yeah.
So I'm not sure if this requires some SQL running in the client side or it's always in the service.
At this moment, I think most of the implementations, and Peter, you can correct me if I'm wrong, but the clients will just provide the content. Hey, I have a patient this age, etc. Show me either the indicators or the signs of risk or what I need to do next. And then this will run on the other client. This is what's currently happening. I don't know if there's clients doing this. Peter can help. Peter is an implementer of the L4, by the way.
All right, thank you. Yeah, so we are running SQL on mobile clients. We run $apply, we run $evaluate measure. It's able to use an updated version of SQL evaluator that's embedded in the Open Health Stack's Android FHIR SDK.
Okay. Thank you. No,
yeah, thank you, Jose. I have one question too, unless there's anything else. On the L5s, you mentioned that there's a dynamic extension past the L4s. Could you talk a little bit about the path you see towards that and your contrast of, now it seems like WHO is going broadly to adopting L3s and L4s, a bunch of different across a number of health use contexts. How would you compare that to focusing on kind of like going deeper and going from an L4 for going to an L5 from an L4 that already exists?
It depends. I do not yet know. I do not know how the local adaptation of those things are. So I do not know if the L4s at this moment, if the tools are flexible enough that you say, yeah, I need the same application, but now in a different language. I would expect this to be kind of present there, or if there is much more to be done after we have a working tool. To be honest, I don't know.
You mentioned that currently published smart guides from WHO are just a start, and there's a wave of new stuff coming towards. Is that roadmap in any way public? Where could I see what's coming in which phase? Where could I contribute?
I think it is. I got this from. Yeah, sorry. The question was there was the audio. The question was if this roadmap that we showed before, this one of the expected upcoming smart guidelines, if it's public. I think it is. I got it last minute from some presentations that I had, so I assume they are public, but they should be published somewhere. We will follow up on that, and I will actually put the source before publishing the slides. I'll put the sources for each of those things so that if you look at the slides, you'll see where the information comes from.
Hi, thank you. My name is Parakisa Tienbaz, and I work with GIZ. And I see that WHO is the place where standards in health can be developed and globally endorsed. And as HL7, from the LMIC, low and middle income country, I see that it's a global North standards, and it's WHO is fast in endorsing standards that are being developed in the global North. So what do you think needs to happen for this standard, these smart guidelines to be also adapted by LMICs? Because I see also that those standards are also being are available either in the language that it's being developed or be translated maximal in English. And I am from a French-speaking country, so I see that for Laserphone countries and French-speaking countries, they are definitely left behind.
Yes.
So what needs to happen for these standards to be adapted?
Yeah, well, let me just go there. I think we had this somewhere. I don't know if I have it. So a couple of things that are needed. So you need to have local capacity in those countries. So that's part of my work, is actually to see how we can do this, how we can develop that capacity, because if you can read an implementation guide, it's better. But if the implementation guide is done in a consistent language, so there's lots of editorial work to be consistent, but you need to have the capacity on site. You need to have either you pool resources between 3 countries that speak the same language in the same continent, or you build local things. So there's a lot of push towards making things accessible. There's the other thing that I mentioned, there's the publication of specifications in a specific language. I live in Belgium, so we have 3 languages, so I know the problem. But this is going to be what I observe, and the work that I do is, if people can speak FHIR in their own native language, the traction is much better. So people can understand the concepts. They will still think in French, in German, in Spanish, but they know how to handle things better. So there's a lot of capacity building that is necessary, not only on the technical level, but also on the people that make decisions, on the clinical experts that will decide, can we put sexual orientation in the HIV reporting? Those people also need to be capacitated, not on FHIR technical stuff, but on data modeling maybe. So there's lots of capacity building, and there's this tooling improvements that we need to do. I can tell you, for example, the CQL stuff. So the technical implementation, the L3s, the level 3, it's something that not many people in the world can do today, which means that we need to have better tooling, automation there, etc. Because if we want to put this in a country, we cannot say, now you have to wait until there's one of the, 12 experts in the world that can actually go to your country. So there's lots of capacity building locally, but the responsibility, and this is kind of the hat that I can put out from Digital Square, is trying to make this as accessible as possible and say, hey, this needs to be much simpler, because we are doing this now. It's fine, but next year we'll have people that don't master the language, they don't master the content yet, they need to implement this on site, and they need to debug, and they need to maintain it. So the LMICs is actually one of the areas that I'm most focused on, because of this industrialization process needs to happen there.
Thank you so much. That was all the time we had for questions. Of course, do feel free to still walk up to Jose. It is break time now, but thank you so much, Jose, for your presentation.
And if you want to reach out to me, chat.fhir.org. If you don't have an account, get one now. Okay.